and welcome to our EBAC accredited webinar from the ISCP's A to Z CV Pharmacotherapy series. Today's program will focus on Clopidogrel or Ticagrelor. Why, when, or for whom? My name is Franco Cheng, and I'm a lecturer from the Department of Pharmacology and Pharmacy at the University of Hong Kong. And it is with pleasure that we're joined today by a fantastic faculty. Today, we have Dr. Craig Beavers, who is the Vice President of the Operation of Baptist Health Petula and is an adjunct assistant professor at the University of Kentucky College of Pharmacy. He is also the chair of the ACC's cardiovascular team section, and he has diverse experience in the field of cardiovascular disease and also clinical pharmacy. And next, we have Professor Diana A Gorog, who is an interventional consultant cardiologist at East and North Hertfordshire NHS Trust and professor of cardiovascular medicine at the University of Hertfordshire and visiting professor at Imperial College. And lastly, we have Mr. Sotiris Antoniou, who is the consultant pharmacist at Boston Heart Center and lead cardiovascular pharmacist for the UCL partners. Today's broadcast is organized by the International Society of Cardiovascular Pharmacotherapy, ISCP, and brought to you by the Radcliffe Cardiology. This is to be an interactive section, which will feature a panel discussion section, followed by a live audience Q&A segment. So please feel free to submit your questions to the faculty via the question box on the webpage, and we will endeavor to answer as many as possible towards the end of the broadcast. So first of all, I would like to hand the time to Professor Gorog, who is going to present Clopidogrel or Ticagrelor. Why, when, and for whom? Professor Gorog, please.
Thank you very much for the kind introduction. So the importance of Ticagrelor and Clopidogrel directly relates to the importance of coronary thrombosis. It wasn't all that long ago, in the 1980s, when the first very large post-mortem study in 100 patients who had sudden cardiac death confirmed that the arteries were blocked with a thrombus comprising of platelets held together by fibrin strands in the vast majority of patients who had sudden ischemic death. And furthermore, in those patients who had coronary thrombus, in the vast majority of those, there was a high-grade stenosis, so a severe narrowing underlying the thrombus. And so that takes us back to why does thrombosis occur? How can we prevent it? And can thrombosis present in different ways in the coronaries? Well, we know from a long way back again that thrombosis can either completely occlude the artery, which causes an ST elevation myocardial infarction. So we see ST elevation on the ECG, and we see the heart being deprived of blood and slowly beginning to infarct. Or if the thrombus partially occludes the artery, or completely occludes and then unblocks and moves downstream, then the heart is not completely occluded in the artery, and that presents in a non-ST elevation myocardial infarction. So thrombosis is a major challenge for cardiologists and cardiovascular pharmacists and other healthcare professionals because the same process can present in different ways. It can present with an ST segment elevation MI, non-ST segment elevation myocardial infarction, and also following angioplasty with a stent thrombosis. Now, the etiology of coronary thrombosis, as I've already alluded to, is that thrombus usually forms on a severe narrowing that has developed over many, many years. So this is cholesterol-rich plaque that, as you can hopefully see on my pointer, slowly develops over time. And then when it gets to be very severe, the thin cap differentiating the contents of the plaque from the contents of the vessel wall can rupture or erode, and that allows the contents of the flowing blood to come into contact with the contents of the vessel wall. And that plaque rupture then starts a series of events which begin with platelet activation and aggregation. So platelets, as they flow past the narrowing, begin to clump together. At the same time, we have activation of the coagulation cascade. And through both these mechanisms, we have the development of thrombin and then finally a buildup of thrombus, which is essentially platelets held together by fibrin strands to stabilize the thrombus and occlude the vessel. Now, why do platelets become sticky and block the vessel? Well, there are many stimuli to platelets becoming activated, but I'm going to concentrate on the ADP receptor on the platelet surface. And this is very important. Whichever route initially activates platelets, whether it's high shear, von Willebrand factor, thrombin, eventually you get upregulation of the ADP receptor, activation of the ADP receptor, and that then causes the platelets to start aggregating. So when do we use Clopidogrel or Ticagrelor in cardiac patients? Typically, we use it as part of dual antiplatelet therapy, so combined with aspirin, 75 milligram daily in Europe or 80 milligrams in the US and in other parts of the continent. But in essence, we give aspirin with Clopidogrel or Ticagrelor to ACS patients. It doesn't matter whether the acute coronary syndrome is managed medically or with angioplasty or bypass surgery. If the patient has had a recent acute coronary syndrome, we would expect them for a period of time to be on aspirin and a P2Y12 inhibitor. The other time when we typically use a combination of aspirin as Clopidogrel is in patients who are undergoing an elective coronary stent placement, and then we give dual antiplatelet therapy again for a variable period of time, which could be a month or up to 6 months, depending on the type of stent used, to prevent stent thrombosis. Now, as part of monotherapy, Clopidogrel can be used instead of aspirin if the patient is truly aspirin intolerant or allergic and can't undergo desensitization. So how do the two drugs compare in terms of their pharmacotherapy? So we've got Clopidogrel, which is a thienopyridine, and Ticagrelor, which is not a thienopyridine, but it's a CPTP drug. Clopidogrel is a prodrug, so when you take Clopidogrel, it has to be converted to the active metabolite by the liver, whereas Ticagrelor is not a prodrug and does not need to undergo hepatic metabolism. Clopidogrel is irreversible, whereas Ticagrelor has reversible effects. The onset of action is again very variable. In a stable, healthy individual, it can take between 2 and 8 hours for us to see the effects of Clopidogrel on platelet aggregation following oral absorption, whereas Ticagrelor works much more quickly, within 30 minutes to 2 hours. The offset of action, again, is variable. You can imagine that with Clopidogrel, you're looking at a longer offset because it's irreversible, whereas Ticagrelor, because it's reversible and because there's a turnaround in platelets, has a shorter duration. The half-life is shorter for Clopidogrel, longer for Ticagrelor, and we know that steady state inhibition of platelet aggregation is achieved in only about 60% of patients on Clopidogrel, but about 90% of patients on Ticagrelor. And the dosing is once a day for Clopidogrel and twice a day for Ticagrelor. Now, this just goes back to show you some of the pharmacodynamic effects. Now, if you look at the dotted line here, which is Clopidogrel, the more dense line is Ticagrelor, and this is placebo at the bottom. And our y-axis is the degree, the percentage of inhibition of platelet aggregation. You can see, first of all, that Clopidogrel has relatively slow onset of action. And then even when you achieve so-called steady state, it really only inhibits about 60% of platelet aggregation. On the other hand, Ticagrelor acts much more quickly, onset of action within about an hour or so, and then achieves between 80 and 90% inhibition of platelet aggregation. Now, how do these compare to just aspirin alone? So, excuse me, We know that in patients who've had an acute coronary syndrome, so that is a heart attack, whether it's an ST elevation MI or a non-ST elevation MI, they have approximately about a 20-25% risk of a recurrent adverse cardiac event if they take no medications over the next year. If we give them aspirin, we reduce the relative risk of heart attack, stroke, or death by 22%. Following the widespread use of aspirin for patients with coronary artery disease, we then had the CURE trial, which added clopidogrel to aspirin, and that combination further reduced the risk of heart attack, stroke, or death by another relative 20% reduction. And we know that using a more potent P2Y12 inhibitor, that is aspirin combined now with ticagrelor rather than clopidogrel, we can further reduce the relative risk by a further 16%. Just to tell you a little bit about the CURE trial. So this trial was published in 2001 and was the first evidence for the use of a P2Y12 inhibitor in patients with acute coronary syndrome. And since then, we've never looked back. This has been the staple treatment for all patients with acute coronary syndrome to use a P2Y12 inhibitor. If you can see here, you can see that compared to patients who just had placebo, those patients who received clopidogrel had a very early and significant reduction in heart attack, stroke, or death, and that persisted right out to 12 months. And of course, that was clopidogrel on top of aspirin or placebo on top of aspirin. But as you can see on the panel on the right, clopidogrel did increase the risk of bleeding, significantly increased the risk of major bleeding, including the need for blood transfusion, but it did not significantly increase the risk of life-threatening fatal bleeding. Most of the bleeding was typically gastrointestinal. Plato was the next study 8 years later, which investigated ticagrelor compared to clopidogrel in patients with acute coronary syndrome. So all patients had aspirin, and half of them were randomized to receive clopidogrel and half of them to ticagrelor. And as you can see again, ticagrelor very significantly compared to clopidogrel reduced the risk of heart attack, stroke, death over a composite of about 12 months of follow-up. And importantly, there was no associated increased risk in bleeding with ticagrelor compared to clopidogrel. What these graphs also show is that the benefit of ticagrelor over clopidogrel in ACS patients was irrespective of how the coronary disease was managed. Whether the patient received just medical management, whether the patient received angioplasty with a stent, or whether they received bypass surgery, ticagrelor appeared superior in reducing cardiovascular events compared to clopidogrel. Now, these are the hard clinical data. You can see that ticagrelor, around 10% risk of stroke, heart attack, or death over the 1-year follow-up, closer to 12% with clopidogrel, and that was driven by a significant reduction in recurrent myocardial infarction and all-cause mortality. What about bleeding? Very similar major bleeding between ticagrelor and clopidogrel. No difference in life-threatening bleeding. There was a significant increase in non-bypass related major bleeding, increase in ticagrelor compared to clopidogrel, but no significant difference in intracranial bleeding. Now, as I've mentioned before, once clopidogrel, ticagrelor are taken orally, these tablets are then absorbed through the intestine. And as I've mentioned before, clopidogrel is a prodrug, so it has to undergo metabolism in the liver to convert it to the active metabolite. This is different to ticagrelor, which does not need to undergo further conversion. Now, going back to clopidogrel, I mentioned that it undergoes metabolism in the liver, and it does so by various CYP, cytochrome P450 enzymes, the most important of which for clopidogrel is the CYP2C19 enzyme. Now, this is relevant because there is variability in the genotype for the CYP2C19 gene, and we know that if you have one mutation, you have reduced efficacy of clopidogrel. If you're a if you have both mutations, so you have 2 loss of function alleles, then you are a very poor responder to clopidogrel, and that drug may not be so effective for you. So how many people are affected by this? Well, most people have no mutation, but about a third of Caucasians and African Americans have 1 loss of function allele, but up to 50% of Asians have 1 loss of function allele. Again, with 2 loss of function alleles, this is where really clopidogrel may not work so effectively. That affects about 2% of Caucasians, 4% of African Americans, and 14% of Asians. So in those patients who have 2 loss of function alleles, there is a 3-fold increase in the risk of stent thrombosis if you just treat them with clopidogrel and not, for example, ticagrelor or prasugrel. So that's very specific to clopidogrel. It's not an issue with ticagrelor, but we need to talk about some of the important side effects of ticagrelor that we need to consider. So one of the things we are always taught about is that ticagrelor can cause bradycardia. So we need to look for conduction abnormalities on the ECG, and it can also make people breathless. So if there is no other reason for the patient to be breathless, in other words, they don't have heart failure, they are not overtly beta blocked, then please consider ticagrelor as a cause for that. And that relates to an increase in plasma adenosine with this drug. So the main side effect, of course, of P2Y12 inhibitors, as I've alluded to already, is that they very significantly increase the risk of bleeding. So we have to balance the risk, the ischemic risk, the risk of thrombosis in a patient with the risk of bleeding on clopidogrel. So how do we do that? Well, we consider patient characteristics, so age, sex, history of prior ischemic or bleeding events, whether the patient is stable with chronic coronary syndrome or whether they've had a recent acute coronary syndrome. Comorbidities that increase ischemic risk include chronic kidney disease, diabetes, peripheral arterial disease, and heart failure. Now, of course, if we're going to give them a P2Y12 inhibitor, we need to be careful if they're also getting an oral anticoagulant. So in combination with an oral anticoagulant, we want to be really careful about giving clopidogrel. So if a patient, for example, has atrial fibrillation, we would want to go with the drug that causes less bleeding rather than more. So we would favor giving clopidogrel with an oral anticoagulant rather than ticagrelor, if indeed an oral anticoagulant is mandated. And finally, we want to avoid procedures that increase the risk of bleeding. So if we do an angioplasty procedure, we want to do that via the radial approach because the risk of major bleeding is very much lower than if we use a femoral access. So these are some of the things that we should consider when assessing thrombotic risk. So I've mentioned diabetes already, but also procedure-related risks, so multivessel stenting, complex coronary revascularization with multiple stenting, multiple overlapping stents where there's a bifurcation lesion, and particularly if you've got a stent in the last remaining conduit. So if the patient has one artery left and it's got a stent in, if that stent goes down, that's really bad news for the patient. So for that patient, you might want to give a more potent P2Y12 inhibitor. And then there are other patient-related factors such as renal impairment and peripheral arterial disease. Now, we can also assess bleeding risk, and we do so by using the HAS bled score. So if you look down the left side, we've got HAS bled spelled out, and that relates to hypertension, abnormal renal or liver function, stroke or prior intracranial hemorrhage, bleeding history or bleeding diastasis, a labile INR if they're on warfarin, age above 65 years, or other concomitant drugs that increase the risk of bleeding, such as oral anticoagulation and non-steroidal anti-inflammatory drugs. And that gives us a score for each of those factors to try and quantify the risk of bleeding for our patients. And that's the score there. And you get a maximum score of 9, which allows you to then gauge the bleeding risk against the thrombosis risk in an objective manner. So I've mentioned that we give aspirin and Clopidogrel or aspirin and Ticagrelor as part of dual antiplatelet therapy for patients who have an acute coronary syndrome or elective PCI. And we've talked about the risk of thrombosis versus the risk of bleeding. But how long do we give it for? Well, if the patient has had an angioplasty and a stent, if they're stable, and if they've had a drug-eluting stent or a drug-coated balloon, if they're at high bleeding risk, then really 1 to 3 months of dual antiplatelet therapy should be sufficient. If they're at low bleeding risk, you would give dual antiplatelet therapy typically for 6 months. Looking at patients with an acute coronary syndrome, if they're at high bleeding risk, then you would reduce your dual antiplatelet therapy for 6 months. But otherwise, if they're not at high bleeding risk, you would give dual antiplatelet therapy for a year. And that's very similar for ACS patients who are medically managed. So 3 to 6 months if they're at high bleeding risk, but otherwise the default is 12 months of dual antiplatelet therapy. And this just goes to show that the earlier you give the P2Y12 inhibitor in a patient with an ST elevation MI, the more benefit you can achieve. So you can reduce stent thrombosis, death, myocardial infarction, and bleeding. So the earlier we give it to them, ideally in the ambulance, which is the standard of care, before they even reach hospital, the better and the more lives we save. So we've talked about the fact that these drugs, when they're given to the patients, need to be absorbed. Now, patients with heart attacks are often in pain, and they're given morphine in the ambulance or diamorphine. And that causes a problem because opiates slow gastric emptying and delay gastric absorption. And that can decrease the onset of effect of oral P2Y12 inhibitors. And you can see here that in terms of pharmacokinetics, patients who get morphine, here in green, have a much more delayed onset of effect with delayed seeing of raised plasma concentrations of Ticagrelor compared to patients who get no morphine. And we also can see that this is the same in Ticagrelor. If you give Ticagrelor with morphine, it takes much longer to achieve therapeutic levels and inhibition of platelet aggregation. Now, to overcome that, we can optimize absorption by giving crushed Ticagrelor with a pill crusher, which achieves a larger surface area and much more rapid absorption than integral whole tablets. And this is particularly relevant for patients who are having a heart attack. Now, this is a very interesting study that came out not all that long ago, comparing Clopidogrel with Ticagrelor in the elderly. So this was a study in patients who were older than 70 years old, 1,000 patients with non-ST elevation MI randomized to either Clopidogrel or Ticagrelor/Prasugrel. And in essence, what this study showed was that there was the drugs were just as safe in preventing the risk of heart attack, stroke, or death in the elderly, but very importantly, use of Ticagrelor increased the risk of bleeding compared to Clopidogrel in the elderly. Now, what about if the patient is confined to, let's say, 1 to 12 months of dual antiplatelet therapy, and they need to undergo some sort of non-cardiac surgery? So for Clopidogrel, we would want to stop this 7 days before surgery. For Ticagrelor, we want to really stop it 5 days, but 3 days is just about acceptable. So longer period of discontinuation for Clopidogrel than for Ticagrelor. But of course, one must always liaise with a cardiologist because it depends when the stent was put in, what the risk might be with the patient stopping the P2Y12 inhibitor. So you never ever stop it without agreement from the cardiologist. So both drugs are P2Y12 inhibitors to prevent arterial thrombosis, given as part of dual antiplatelet therapy to reduce the risk of thrombosis, particularly in ACS patients, but also in stable coronary disease patients who are undergoing elective stenting. Both drugs increase the risk of bleeding, but Ticagrelor may do so more than Clopidogrel, particularly in the elderly. Ticagrelor achieves much more rapid onset of effect and provides much more potent inhibition of platelet aggregation than Clopidogrel. And generally, Ticagrelor is only indicated in patients with ACS, whereas clopidogrel can be used typically in stable coronary disease patients undergoing stenting, but also in patients who are at high bleeding risk with an acute coronary syndrome. And in deciding the duration of treatment, we should consider the risk of thrombosis versus the risk of bleeding to individualize that to reduce the risk of bleeding for the patient. So thank you very much for your attention.
Thank you. That was a great overview of the landscape of who and when. And so I think at this juncture, we're going to transition into making it a little more applicable or application-based and contextualize all that conversation with questions and added experience. So I think we have some cases to go through that will highlight some of the conversation that we just had. So first to present, JJ is a 57-year-old male. He weighs 70 kilograms. He has a current past medical history that includes heart failure with preserved ejection fraction, hypertension, type 2 diabetes, and epilepsy. His home medications include losartan, 100 milligrams daily, spironolactone, 25 milligrams daily, and empagliflozin, 10 milligrams daily, metformin, 500 milligrams twice daily, and levetiracetam, 500 milligrams twice daily. So he is called EMS, or the ambulance, for crushing chest pain that is not responsive to nitroglycerin. He has ST segment elevations on the ECG and the inferior leads, and he is taken immediately to his closest or close PCI percutaneous capable hospital. He has chewed up 324 milligrams of aspirin in the ambulance and is given 5 milligrams of IV morphine on arrival, has alluded to. In the lab, he is immediately taken to the lab and he's given 500 units of heparin bolus. And so kind of the conversation to Dr. Antoniou and the team is kind of some of the questions and discussions points I want to highlight in this instance and based on the information we just presented. So what, in this situation, P2Y12 inhibitor would you give to this patient? And knowing if you see our poll, you should say, should every patient admitted with ACS receive a more potent antiplatelet rather than clopidogrel? And right now, the audience is leaning to yes. So I would love to hear, what your thoughts and opinions are, especially in a case like this, knowing he's gotten morphine at this juncture and looking at it from that context. So.
Yeah, many thanks, Dr. Beavers. I think firstly, I'd like to thank Professor Gorog for a really interesting talk, a nice summary of the process of acute coronary syndromes and platelet activation aggregation, which is so important and helps summarize the importance of dual antiplatelet therapy. But I think it comes back to Dr. Beavers' case around a popular age where the ischemic versus bleeding risk comes to apparent. So certainly, I think for somebody who's quite young, he was 57, 70 kilos, would anyone here go against Ticagrelor, especially on the basis that he's likely to receive morphine in the ambulance? Would anyone go against Ticagrelor as a loading dose of 180 milligrams to administer that? And then maybe there'll be some questions as to where there's a glycoprotein 2B3A on top of that. I'd be interested to see what others' viewpoints are on that. Perhaps we go to Professor Gorog in the first instance.
Thank you. So really good case and really good discussion points highlighted there. So my first thought, exactly as you've said, so this patient is at very high ischemic risk. He's already got a thrombus. We're about to do an emergency angioplasty. And the last thing we want is for that stent to block off. From what we know about him, there is no major bleeding risk. So immediately I'm thinking a potent P2Y12 inhibitor. I'm already thinking Ticagrelor. I'm also mindful, of course, that he's had morphine. So we need to get this drug on board very quickly. We should be crushing the Ticagrelor and getting this in as soon as possible. I wouldn't be giving him anything else.
So to contextualize this as well, and writing this case, I wanted to put out there, and in case you're in an area of the region that does this, are you guys or anybody using Cangrelor? And just the reason I bring that up is clearly because there's a transition concern depending on which agent you use and how to contextualize that. And there's one item we didn't necessarily touch in the particular lecture, but just for completeness sakes, if someone were to get intravenous Cangrelor, kind of what what the thought process there. Why would this patient be a good person for that medication? And then B, if we were to use it, to talk a little bit about that transition piece.
So would you like me to address that, or
please?
Yes?
Okay, go ahead, and I'll come in after.
Yeah, so certainly as an interventional cardiologist, we would use Ticagrelor in two scenarios. One is where the patient is unable to have anything by mouth. So if the patient, for example, is intubated, ventilated, they've maybe had a cardiac arrest, and they are brought in with an anaesthetist, ventilated, and we haven't yet got an NG tube down. And even if they've got an NG tube down, in the setting of cardiogenic shock, absorption from the gut may be very slow and limited because of splanchnic shutdown of the circulation. So in that setting, either in a person who's unable to have anything orally, or in the patient who's in cardiogenic shock with very low blood pressure, poor perfusion of their internal organs, that's when we would be using Ticagrelor typically to very quickly get a Y12 inhibitor on board. And then, of course, we don't use this for everyone because there is a very significant cost to using Ticagrelor. And at the end of the Ticagrelor infusion, we hope that we would, by that stage, get an NG tube down and transition to Ticagrelor typically.
Sure, that's great. And just, Dr. Antoniou, what were your thoughts on this?
Yes, it's really interesting. We looked at Ticagrelor locally. I think for us, our local practice is we tend to give a bolus of glycoprotein 2B3As purely as a bolus at the same time. But there is the recognition, as Professor Gorog has highlighted, that if you aren't able to administer an oral drug, we like to give the bolus of the glycoprotein 2B3A if they are considered high risk of a big thrombotic event, just to help recognizing that we've got a morphine delay and to help with the absorption of the Ticagrelor. So I think it sounds like everyone's very keen to get this patient on a more potent oral antiplatelet. And interestingly enough, I think as we come towards the bleeding risk, I think it's really important just to recognize that the bleeding risks are cumulative. So if you were to compare various loading doses that we've done with Clopidogrel dosing, so AMIDA 4, which looked at 1,200 milligrams of Clopidogrel, 900 milligrams or 600 milligrams, there was no difference in the risk of major bleeding. The risk of major bleeding tends to be cumulative, i.e. the longer you're on a dual antiplatelet therapy for, the more likely you're going to come out with the risk of major bleeding. And that's where we need to think about mitigating the risk. So acutely, I think everyone should think about having a more potent oral antiplatelet, recognizing that having a STEMI, you've got that platelet activation, aggregation, as Professor Gorog has alluded to, plus the addition of potentially a PCI that also adds to the platelet activation.
And that's great. And you alluded to a lot of good points there. You're pointing about 2B3 inhibitors. Well taken. We've clearly seen data like Fabulous Pro and other things that indicate that if you give a bolus and give it, you can get a profile that's similar to an intravenous agent. And then your bleed risk is very much pertinent. And Dr. Gorog mentioned that in her presentation about, especially looking at how are we pursuing the intervention, whether it's radial, what does that look like, and the risk factors and the bleeding risk that is there. And of course, obviously, the option to crush the agent as well. I do want to go to a question or two questions that are in the chat, and it's very much related to, you can't talk about Clopidogrel and Ticagrelor without talking about the third agent, Prasugrel. And so, Dr. Gorog, Dr. Antoniou, given the findings of ISAR React 5, should we consider moving to Prasugrel or, in preference over Ticagrelor and PCI? And I know the conversation is Clopidogrel versus Ticagrelor, but you can't skirt around this question at all. So,
shall I start, and then Professor Gorog will alternate it? So I think there's a lot of validity of Prasugrel. Certainly in the UK, Prasugrel is generic, and that's certainly stimulated a lot of discussion with Prasugrel. So certainly for those who are high risk ACS who've undergone PCI, ISAR React 5 would suggest Prasugrel is certainly non-inferior, if not superior. And interestingly, when you look at the Triton-TIMI data and you look at the duration of therapy that related to the risk of major bleeding, the more longer you're on it, that's when they showed the risk of major bleeding. So as a reminder, tritontimmy was up to 15 months, and that's where it showed that increase in the risk of major bleeding. So when they went head to head, because they're both more potent oral antiplatelets in comparison to clopidogrel, there was no difference in the risk of major bleeding. So I think we just need to be mindful as to how we manage acute coronary syndrome in wherever you are, whether it's medically managed, PCI or bypass. But certainly there could be an argument that for those high risk ACS that go straight to PCI, whether you use prasugrel or ticagrelor is irrelevant. I think they're both equitable agents, and so I'm happy to consider that. And then for those that are for medically managed, you'd argue there is no data for prasugrel in the medically managed group, and if anything, there's been shown to be an increased risk of major bleeding in a medically managed group. Be interested in Professor Gorog's.
Yeah.
Indeed, I think that's a very good. These are all very, very good points. I agree. I mean, I think we have to take ISR React with a pinch of salt, in that it was a good study, but it's not it was an open label study. It was not a typical double-blind placebo-controlled trial. But nevertheless, I think we have to say that it did show a benefit. But I think we tend to think of these drugs certainly in terms of the inhibition of platelet aggregation. The pharmacodynamics are essentially very similar with ticagrelor and prasugrel. So from a pharmacological perspective, what we are achieving is the same. I think nuances in studies are just that. I think we need to be mindful that prasugrel certainly does very significantly increase the risk of bleeding. So I think if bleeding is not a major issue, then I think one can debate whether you go with ticagrelor or prasugrel. Pharmacodynamically, they're exactly the same. I think if bleeding is an issue and you want to reduce ischemic risk, but you are worried about an excess risk of bleeding, I would prefer to use ticagrelor because the bleeding risk is certainly lower.
No, that's a very good conversation and all that in context. And you could also argue with Triton, there was clearly a benefit in diabetic patients, and our patient is diabetic in that context. And relate it to one of the questions in the chat, and you alluded to this in your slides, what about when you're choosing this for an elderly patient or choosing your oral P2Y12 inhibitor for an elderly patient? And I think you kind of touched upon that in your conversation. So just if you want to elaborate on that for the audience.
Yeah, so I think that's a really good point. And I think we used to think all patients were equal. We're now much more focused on the elderly and realizing that we must minimize harm in these patients, as well as, of course, preventing thrombosis. So I think I would take three things into account. I would take the patient's ischemic risk into account. I would take the patient's bleeding risk into account, and also, very importantly, consider how their acute coronary syndrome was managed. So for patients who are medically managed and who may be at moderate or high bleeding risk, so in an elderly patient who's medically managed, I would feel far more comfortable using clopidogrel if they're at excess risk of bleeding. I think if the patient has a stent for an acute coronary syndrome, then I think it really boils down to, is the bleeding risk higher than the ischemic risk? So, and that depends on the patient risk factors. So obviously not just their age, but do they have CKD? Do they have diabetes? Are there procedural factors? So long lesions stented, multiple stents. If they don't have any of those high risk features, if it's just age, then I would probably go with ticagrelor. But if it's high ischemic risk and high bleeding risk, then I would look at which, trying to balance the two to achieve a reduction in ischemic risk without an excess risk of bleeding.
Very good. If we could go back to the cases, I see a question that is going to probably be better set up for our second case as we go through this in consideration. So LL is a 65-year-old female who's 68 kilograms. She's status post-PCI to the LAD for an NSTEMI. The patient had 2 drug-eluting stents, placed her mid-LAD. She was a current smoker, and her EF is normal post-myocardial infarction. She had a past medical history of hyperlipidemia, hypertension, and gastric ulcers. She had, at the time, CYP2C19 testing sent, and we're waiting for the results to come to that. And we talked a little bit about that during conversation. And she's concerned about being able to obtain her medications. And so in this context, and we can contextualize it both depending on her genetic results, what do you consider as your choice in this instance? And then kind of thinking about if she develops adverse side effects like dyspnea, what do you do if you were to pick Ticagrelor? And then more related to our question that we have from the audience, what do you do with your dual antiplatelet at 30 days, at 1 year, and at 3 years out in a more chronic situation? So I'll pause there. A lot of different questions to think through in this scenario, but just, given the different things that we're waiting for from a data point, how does that drive your decision?
So very, very interesting case. Again, relatively young, but as Professor Gorog's already alluded to, we need to think about what's the ischemic risk. You mentioned that we've got a PCI to LAD, also 2 drug-eluting stents, and we know that the more stents that you put in, the greater the risk of acute stent thrombosis. So we need to think about that as a potential thrombotic risk, but also take into consideration the bleeding risk. The other thing to just be mindful when you're interpreting clinical trials, in particular regards to oral antiplatelets, so the Plato or the Triton TIMI, we just have to be mindful that every single clinical trial has an inclusion criteria and an exclusion criteria. And if you look at some of the exclusion criteria, they'll often talk about patients who've had a recent high risk of major bleeding, or a recent major bleed would have been excluded in the clinical trials. And often patients with many comorbidities or end-stage kidney disease or liver disease, these patients would traditionally be excluded from clinical trials. So we just have to bear that in mind, which is why it's so important that we look at the individual in front of us and not just apply the clinical trials just blindly thinking that Ticagrelor will be superior for everyone. And which is why I'm a big fan of the popular age around highlighting that we do need to think about, you will get the reduction in efficacy, but at the expense of major bleeding. What we need to do now is apply those clinical trials to the individual in front of us. Locally, we assess the risk of thrombotic based on GRACE, and we use Crusade, which is a major bleeding risk score based on real-world registry data. And with Professor Gorog's highlighted about it has bled. So we need to have some way of assessing that bleeding risk and then decide as to which is the more appropriate agent. Interesting, you mentioned about the CYP2C19, and it'll be interesting to see whether people apply that into clinical practice locally and whether that would define people's choice of therapy. But my feeling is at the moment is, and I appreciate that the US may be slightly different in many countries where they pay for their prescriptions will be variable depending if it's Ticagrelor or Clopidogrel. But certainly within the UK, the choice is the same. We will still most likely go with Ticagrelor, assuming that the bleeding risk is suitable, especially noting that we've got the 2 drug-eluting stents. And one of the key questions would be, are they kissing stents? Are they doing any other things that may increase that risk of thrombosis?
Perfect. And I'm going to let Professor Gorog add her commentary.
So I think I would just come back to the financial situation in other countries. Certainly in the UK, we're in an enviable position that it's not an issue. But I would say that the most important thing for this lady is that she is on a P2Y12 inhibitor. So if she's on Ticagrelor and there is a risk that she will stop it because she cannot afford to renew her prescription, I would rather she was on Clopidogrel, or I would give her a backup prescription. Of course, ideally, we would want this lady on Ticagrelor. She's an acute coronary syndrome. She should be on Ticagrelor. But if there's a financial risk, then let's give her Clopidogrel. And of course, let's get her tested to see if she's got one or more of the loss of function alleles. But probably just want to make the point that it's important that she just gets a P2Y12 inhibitor.
Sure. And let me ask you this, and kind of related to the question in the chat box, but just putting this all in context, are you, in your practice, in a patient like this or looking at it, changing your duration of dual antiplatelet therapy based on their bleeding risk? Are you continuing beyond a year if it's a higher risk patient? How are you evaluating this? I left the patient a little open-ended to be able to have these conversations, but obviously a lot of hot topic is based on master DAPT and Twilight and all the other things. Do we do a shorter course? Do you do the 12 months? Do you go beyond 12 months? What are you looking at for this particular patient? So
I think practice is changing. I think maybe 5 years ago we would be doing a one-size-fits-all of 1 year DAPT following an ACS. I think practice is definitely changing. For a number of years now, I think if the patient is at low bleeding risk and they come to the end of 1 year and they've tolerated the P2Y12 inhibitor well without bleeding, and they have additional ischemic risk factors, typically type 2 diabetes, renal impairment, long segment of stenting or prior thrombosis, you might continue Ticagrelor at 60 milligram twice a day for a further 2 years, so a maximum of 3 years. Again, with increased awareness over the last few years of the risk of bleeding, and particularly with the number of studies that have now come out in favor of de-escalation, so reducing either the intensity or the duration of antiplatelet therapy, we are again much more mindful of that. So I would feel far more comfortable de-escalating now than I would have a few years back. And that's really de-escalation either by giving Ticagrelor maybe just for the highest risk period, which is usually the first 1 to 3 months. And then you could either stop the Ticagrelor altogether, or you could de-escalate to Clopidogrel for the rest of the 6 months or a year if you're really worried about high bleeding risk. And the other possibility is just giving dual antiplatelet therapy for 6 months and stopping it altogether if you're worried about an excess bleeding risk. So I think increasingly practice is and should be much more personalized than it has been in the past. And we should be not only making that decision at the time when the patient is discharged from hospital, but reassessing that patient at 1 month, at 3 months, at 6 months, and then at a year. And at each time point, asking about bleeding, assessing bleeding risk factors, and considering ischemic risk and reevaluating.
Yeah, I think that's really
Dr.
important.
Cheng, would you like to add or? Oh, go ahead. Sorry.
Sorry, Dr. Beavers. I think it's really important to recognize that even though somebody may have come in with acute coronary syndrome and had that one event, we're not changing the pathophysiological process by putting a stent in. And so there is that risk of the subsequent events. And some of the data is showing us that often they'll come back with another heart attack, but in a different artery. So it's really, really important. And we are noticing about individualizing therapy where we may give somebody Ticagrelor even just whilst they're in hospital for that acute period and then switching, or over 3 months switching to Clopidogrel. I think most people feel more confident for trying to extend the duration of dual antiplatelet for as close to the year as possible, but more and more data. And as the stents improve, with reducing that thrombogenicity associated with the stents, hopefully that will give us more and more data that we can stop the dual antiplatelets even earlier and subsequently reducing the risk of major bleeding earlier.
No, your point is well taken. When I educate patients about anything post-MI, I always remind them the importance of their secondary prevention. I said, because we have not actually fixed your disease process. We have put a Band-Aid on it for the time being. They think because they were in such bad chest pain and we've done something that they're cured, and this is a mitigating factor. We still have a lot of work to do beyond this standpoint. Dr. Cheng, would you add anything or have questions that you'd like to ask to the team?
Well, yeah, actually, yes. Concerning the 2C19 polymorphism, because as Asian, the prevalence is much higher than in the Western countries. So we don't normally do the genetic test in Hong Kong, but sometimes we actually do the platelet reactivity during the test to see how reactive the platelet is. Do you guys have any experience on the use of the PRU instead of the genetic testing regarding the use of antiplatelet? Maybe Professor Gorog?
Yes, indeed. So the tropical study looked at this. So in tropical, they de-escalated from prasugrel to Clopidogrel in people who were pharmacodynamically responsive, so they had good inhibition of platelet aggregation. That seemed to be a safe approach to reducing the risk of bleeding and ischemic risk. And I think just coming back to you about ethnic variability, I think that's very important because we also know that East Asians are at higher bleeding risk than other populations. So I think many of the guidelines in East Asia would recommend a lower intensity of P2Y12 inhibitor, so more often using Clopidogrel than Prasugrel or Ticagrelor, unless, of course, there are very high ischemic risks in the patient. But I also share your point that that sensitivity, the genetic testing for Clopidogrel is not widely available. So it is available much more in the US than in many parts of Europe. And also, it may not be so quick to do. Although there is a point of care test, many centres still rely on sending a sample to the laboratory. And of course, by the time you've done that and the patient comes back, you've exposed them potentially to risk. So on a practical level, I agree with you. I'm not sure how useful genetic testing is. I think if you really wanted to be absolutely sure, I guess you would combine genetic testing with platelet aggregation.
Any comment for you, Sotiris?
Yeah, we probably use 2/3 Ticagrelor, 1/3 Clopidogrel. And in our local population, we're very big on South Asians. And I've always got that thing in the back of my mind as to how many of our patient population have got this 2C19 genomic factors. And we're quite fortunate in that genomics is becoming more mainstream in the UK now. Hopefully there's going to be some further opportunities for genomics. And so I think this is going to be quite interesting. And in fact, a small group has looked at our patient population to look at specifically the 2C19 allele and our local population, and it's quite prevalent. So we're now starting to wonder whether that's translating to differences in the expected outcomes that we would expect by giving in these patients Clopidogrel. So I think it's, we've looked at very far now, and if you look at the platelet aggregation data, it's not as strong as perhaps we would have liked, and it doesn't translate to the clinical outcomes that we may have expected. And so we just have to recognize that this is very multifactorial. And, simple things like the biggest contributor to stent thrombosis is that premature discontinuation of dual antiplatelet therapy. And so you do wonder whether the genomic factors will play a bigger part if we had more of that data and how that translated into the real world outcomes. But I think we're still waiting for that big data analysis to give us that true assessment.
Thank you. So I think that concludes our panel discussion as well. And I think we also answered quite a number of questions from the audience. But we do still welcome any questions. And I think one of them is about the use of bleeding score. I think Sotiris mentioned that you use Crusade score a lot more than the Hasselblad score. Can you comment on any reason why you prefer Crusade score over the Hasselblad one?
I think the main thing, if I was to really take away, people are more familiar with the Hasselblad simply because of the atrial fibrillation, which was much more awareness from the Hasselblad score. And some of them are similar factors. The reason why we use the Crusade is that it's a bleeding risk score that's derived in acute coronary syndrome patients. And so from our perspective, it's more accurate. You would argue it has the more relevant factors, and it has been shown in relation to the ACS. I think I would just take away, whilst we're focusing on bleeding and maybe have that debate, we're starting to learn more that if you have a major bleed with people with acute coronary syndrome, it's translating to a high risk of mortality. So we do need to assure ourselves that we are trying to mitigate the risks where possible. And so hopefully one of the key messages for me is not to just blindly think that a more potent antiplatelet is suitable for all. And hopefully we've discussed a lot around the ischemic risk and the potential bleeding risk. And just think about that frail old lady who comes in, and think about whether Ticagrelor for 12 months is the most suitable, or whether we think we might be increasing their risk of major bleeding and actually translating that to increasing their risk of harm when perhaps a more appropriate antiplatelet might have been that choice. So we use the Crusade, and that's because it has been derived within an ACS cohort. I'd be interested to know what others are using, if any.
I have to say, we've been using the HAS-BLED score because it's easy to use. But I completely agree with you. That Crusade is much more validated in an ACS population. I think at the end of the day, it really doesn't matter which score one uses. Most of the risk factors are overlapping. The other thing to bear in mind is that the risk factors sometimes overlap between the ischemic and the bleeding risk scores. So it's all very, and we don't have an ischemic risk score calculator. So there isn't a magic sort of, if this number is this and that number is that, then the balance tips in favor. I think one has to, this is where we still have to individualize patients. And of course, the other thing to think about is whichever score you use, some risk factors are modifiable. So we should be putting these patients on a P2Y12 inhibitor. We should be controlling their blood pressure. We should be looking at if they've got impaired liver function. Again, we should be advising them about avoiding excess alcohol. So all the things we can do, which is not just assessing risk, but modifying the risk factors. So I think that's probably another point to make, to assess the risk and then to reassess to see if the patient's modified those risk factors.
Well, to those points too, depending on their risk over time, if you're on a potent agent, dropping the aspirin, removing other things that are additive bleeding risk from that standpoint. All right, Dr. Cheng, I think we have to wrap up at this juncture.
Yeah, I'm afraid that's all the time we got to today. So I'd like to remind all of you that today's proceedings will be shortly available on demand on the www.radcliffecardiology.com. So to get access to more content and learn about the opportunities offered by the International Society of Cardiovascular Pharmacotherapy and how to become a member, please scan the QR code or visit our website. So and stay tuned for the next webinar of A to Z CV Pharmacotherapy series, which will be held on 8th February 2023. So mark your calendars, and more details will be coming soon. So before we go, we'd like to thank you, our faculty today, for all the fantastic contribution. Professor Gorog and Mr. Antoniou, and finally, Dr. Beavers.
Thank you.
We would also like to thank you, our sponsor, AstraZeneca UK, who have supported this section for an unrestricted educational grant. And finally, thank you to all of you, our audience, for joining us. It's a little bit late in Hong Kong. It's already 1 a.m. So I'm ready to wrap up and go to sleep. So we hope that you have found this insightful and to have met its objectives. So remember, this event is a CME accredited. So please don't forget to submit your details to claim your certificates. Thank you, and goodbye and good night.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Bye-bye.